Hi, Aarti. Hi, Ronak. How are you?
Yes, sir. Fine, sir. Fine.
Is Aarti there? Okay, Aarti. Is Aarti there, or who is the host today? Who is the representative of Imagicare Health? Okay, I think there is nobody else responding. So, shall we start the discussion, Ronak? Are you ready?
Yes, sir. I'm ready, sir.
Are you getting the screen share facility?
Yes, sir. Yes, sir. Yes, sir.
And ask them to give you the screen sharing facility. So we'll start the discussion, and I would request somebody to discuss the case one after the history presentation by Ronak. Shall we invite somebody who would be willing to do that? Gaurav, can you do that? Gaurav, Gaurav Pandey, are you there? Anybody who would like to discuss the case after Ronak has presented the story part? Arun Kumar, would you like to discuss the case? Ashok, Dr. Sheshagiri, would you like to discuss the case? Okay, we'll ask Saroj to do it. Saroj, can you discuss the case? Saroj, are you there?
Yes, sir.
Yeah, okay.
Yes, sir. I am there, sir.
Okay. So after Ronak has presented the story, you will initiate the discussion. Everybody can join. I also will guide, and then subsequently we go to the physical findings and final diagnosis and management.
Yes, sir.
Okay, wait, let me increase the screen size. Okay, fine, great.
Can I start, sir?
Yeah, please.
Yeah. Patient name Miss Sahin Pathan, age 10 years, female, occupation by student, religion Muslim, address Palsana, Surat. Date of admission is 13/1/2022 through OPD, and date of examination is 14/1/2022. Chief complaint of bluish discoloration of tongue, lip, fingers, toes during exertion since childhood, breathlessness for 2 to 3 weeks. According to the statement of the patient's mother, give the history of episodic bluish discoloration of skin, fingers, nail, toes, and lip during her childhood, which is more marked during exertion. She used to get relieved often with sweating, and it persistent and gradually progressive, becoming more marked on exertion and not associated with change in temperature and exposure to cold. She also has been suffering from shortness of breath during exertion since her childhood. Initially, it was on moderate to severe activity, but it is progressively increased. Now it occurs on mild exertion for last few weeks. She felt comfortable at rest and on lying flat, and there was no history of sudden awaking from the sleep at night due to breathlessness. Breathlessness occurred during playing and relieved on taking rest. Or breathlessness is not associated with cough, chest pain, fever, cough without blood, and there is no seasonal or diurnal variation, wheezing, history of allergy or swelling of the any part of the body. It does not aggravate on exposure to cold, dust, fumes, or any allergens. She mentioned fatigue during competitive activities during her childhood. Her mother also mentioned that patient used to become bluish and breathlessness while feeding or crying during her childhood. But there was no history of palpitation, dizziness, sudden transient loss of consciousness, headache, blurring of vision, nausea, vomiting, bleeding, or any site of the body fever, joint pain, or swelling. There is no history of repeated recurrent respiratory tract infection, weakness of any part of the body, but she has stunted growth. Her birth history was uneventful and her growth were delayed. Birth history, patient was born out of non-consanguineous marriage at full term with normal vaginal hospital delivery and is vaccinated till date for the age. Birth weight was 2.7 kg. Maternal history, no history of diabetes, hypertension, or other major medical illnesses in mother. Family history, no such illnesses run in her family.
Oh, okay, right. So, from your story, Saroj, do you think that the story is perfect, or you would like to get some more information?
Yes, sir. Little more information, sir. Exact timing of bluish discoloration when first noticed by the parents.
I think that's very important, Ronak. You must always mention, especially you should mention whether during the hospitalized period, did the doctor or the parents or the grandparents of the child noticed any bluish discoloration? When was the first time the bluish discoloration was discovered or identified by the parents? That's very important. Okay, right. Ronak, when was you mentioned that this was detected in childhood. So what age at which, what may be the period at which?
Sir, as per the as she was not confirmed as she used to tell that while feeding the baby become very irritable and starting with crying, and she noticed approximately she is not confirming the exact period, but after the 6 months she was noticing that.
Okay, so we can take it granted. Same, it's quite possible that she might have had a very mild cyanosis to start with, which the parents might have missed, but they noticed for the first time around about 6 months. Okay, that's fine. So whatever is information available, we can, because it's very important to include in the story when was the cyanosis identified by the parents or by the doctor for the first time. Obviously, the doctors did not tell about the bluish discoloration. So obviously, the bluish discoloration was not there on the first day or the second day of delivery. Okay, Saroj, anything else? That's very important point.
Yes, sir. When Dr. Ronak is telling that it has started around 6 months, so sir, from the history, it seems that it is a congenital cyanotic heart disease.
No, any other information you would like to have?
Oh, okay, sir. Sir, I think he has given other history. He has not mentioned about how this cyanotic spell, we can say that.
One more important thing. I would like to have a few more stories. One important story I would like to have is that you mentioned about the difficulty in feeding and crying. Was the crying associated with any acute increase in the bluish discoloration?
Yes, sir.
There was an acute increase in the fluid discussion during the time of the okay. When did during the developmental milestone, you should describe both about the physical milestones as well as mental milestones.
Okay, sir.
Both relate. What do you mean by physical milestones and what do you mean by mental milestones?
With physical milestone, sir, baby used to walk at around 1 year. Then
At what age does the children walk? Is it at 1 year, 2 years, 6 months?
Crawling start at the 6 month, 6 month, and walking start around 9 to 12 months, sir.
Okay, mostly by about 1 to 12 to 15 months. They stand up by about 9 to 10 months and start walking by about 12 months to 15 months. Okay, right. So in that case, there is no delay in the physical milestones. Because at what age did the child turn over? At what age did the child sit up? And what age did the child start crawling, standing up, and walking? These are the important physical milestones. So, did you ask for that?
No, no, sir. No, sir.
You should always ask for that because physical milestones are extremely important because most of the cyanotic congenital heart disease is associated with delay in both physical and mental milestones.
Mental mind, sir. Yeah.
What are the mental milestones?
Sir, so social smiling occurs at the age of 6 months. Then a monophasic word, single word start around 1 year, and sentence or double word sentence at around 1.5 year to 2 years, sir.
Before that, the child starts identifies the mother at what age?
Sir, 4 to 6 months.
No,
Fourth
no,
month.
much earlier than that. 1 to 2 months.
1 to 2.
Usually the mother is identified by about 1 to 2 months, and from the expression of the baby, it is very clear that it is the mother who is coming. So identifying mother, that's very important. Identifying strangers. See, when the patient is when the child is brought to a doctor, the doctor is a stranger, so the child cries.
Yes.
So identifying the stranger, all those are intellectual milestones. Okay, so that's very important to ask the story. Second thing is that when the patient was discharged from the hospital, did the doctors tell, if I got you correct, the baby was born in a hospital, is that right?
Yes, sir. Yes, sir.
So when the baby is discharged from the hospital, did the doctors tell the mother that the baby is having a heart lesion?
No, sir. No, sir. No, sir.
What does that indicate?
This indicates that either the disease was so mild that it was not diagnosed by the parents as well as the doctor, or there are few diseases which has got a signs so subtle that they cannot be picked up in the newborn baby.
Rather than that, I would say that if the doctor said that, as I agree with you that the manifestations are mild, on top of that, there is no significant murmur. Because usually the doctors auscultate, and anyway, if there is a loud murmur, it will be immediately detected. So if the doctors, if a pediatrician or somebody has examined the baby before the baby is discharged, and has said and did not mention to the mother that there is no heart lesion, then that will make you suspect that unlikely that this baby is having a loud murmur. Most of the times the loud murmur is picked up, and the loud murmurs are produced in a cyanotic congenital heart disease by presence of a
systolic murmur.
Systolic murmur. It's RV outflow obstruction. It's RV outflow obstruction that generates a murmur. And if the on discharge from the hospital, the doctors did not had examined the patient, examined the baby, but did not mention about a heart lesion, then most likely the baby may not be having any loud systolic murmur. The loud murmurs are usually the RV outflow murmurs, which are easily picked up by the doctor. It can still be pulmonary atresia, but pulmonary stenosis is unlikely. Okay, right. Yes. Pulmonary atresia is a condition where there may not be any murmur, may not be a loud murmur. The baby can have continuous murmur in some other part of the body, but mostly it is the RV outflow murmurs which are very easily picked up by a pediatrician or by a doctor who is examining the baby in his first or the second day of postnatal life. Okay, so that is something which then you should always give negative points also. There is no history of cyanotic spells. So it's important to mention, obviously you have said that there is no loss of consciousness and all, but it may be worthwhile telling that there is no history of cyanotic spells. Just like you mentioned that there is no history of recurrent respiratory tract infection, you may also mention that there is no history of cyanotic spells.
Okay.
Then you must also mention whether the squatting episodes have disappeared. What is the usual pattern? At what age does the squatting start appearing? And at what age the child usually stops squatting?
Sir.
Yes, Ronak.
Sir, usually squatting start at around 6 months and used to disappear around 2 years of the age.
Now, how can the squatting start at 6 months? Because does the baby start running about by 6 months?
Sir, as the baby grown, and along with that, there is a progressive pulmonary stenosis, increase in the stenosis, which might causes increase in left to right shunt. The episode used to start at around 6 months.
No, so you said increase in pulmonary stenosis will increase left or right shunt?
Sorry, right to left shunt. Sorry,
Right,
right
left.
to left. Right to
But
left.
then if you are asked a question about squatting, for squatting, child has to be walking around. Otherwise, you will have to mention about squatting equivalents. What do you mean by squatting equivalent?
Uh,
What do you mean by squatting equivalent?
Squatting equivalent is posture of the body.
Ah.
A physiology will be like a squatting, like sir, baby in the mother's lap.
Hmm.
Sir, if the bigger child is there, then sir, crossing of the legs or sir, flexion of the at the knee joint and hip joint and making both the limbs near the abdomen.
Yeah, the baby can attain all the four limbs flex position. That is, or baby, if the baby is carried by mother, the baby may still adopt a flex position. So if the limbs are flexed, that will have something like a the squatting equivalent. If usually the squatting starts by the age of 2 when the baby starts running about, and by it dissipates by about 6 to 7 years. That's usual pattern. So it starts at 2 years, and usually it starts disappearing by about 6 to 7 years of age. Did the squatting disappear in this baby, or is it still present?
s-
You have not mentioned that. It is. You said it is becoming more frequent, but you have not mentioned whether he's 10 years of age and is he still having squatting episodes, or is it has disappeared now?
Sir, as per the mother mentioned, she mentioned that on exertion, baby has breathlessness and some bluish discoloration. But as soon as with her body posture, change in the body posture, the breathlessness and cyanosis get relieved within 10 to 15 minutes, and she became normal with her routine activity.
Okay, that part is right. What I want to ask is, still the baby at the age of 10 also still having squatting episodes?
Yes, sir. Yes, sir.
We just still have. Okay. So why? How can a squatting episode disappear? What is the mechanism? Why does the squatting episode disappear?
Like sir, squatting episode can appear sir, first the baby learn and decreases the exercise that she or he may be getting the squatting. Sir, so exercise will be decreased by the baby.
Okay, the baby can voluntarily reduce the exercise so that she does not have to squat. All right. Okay. What else? Any physiological changes which can reduce the
Yes, sir.
frequency?
Infections also starts decreasing, sir.
But
After the,
usually in a low flow group, usually major lower respiratory tract infections are not that frequent. They can develop bronchitis, but not severe lower respiratory tract infections are not that frequent. What is the purpose of squatting?
and the
Why,
purpose
why squatting? How does the baby get a relief? What are the mechanisms of relief of symptoms when the baby is squatting? Hemodynamic changes.
sir, in the squatting, there is a sir, increase in the oxygen saturation because of the flexion at the hip joint, the
Mm.
lower limb blood to the heart will be decreased, and
Mm.
there will be an increment in the venous return from the abdomen.
Why
Uh,
there is increase in why there is increase in the venous return from the abdomen?
Because in the squatting posture there is an abdominal compression by the legs and the knee.
Okay, the intra-abdominal pressure goes up. That will result in squeezing the abdominal veins, and consequently the blood can drain back into the
IV supply.
right atrium. What is the benefit of this thing happening? That the blood
The
flow,
benefit of this is that
venous blood from the lower limb is cut off, and venous return from the abdomen is increased. What is the benefit?
the venous blood flow from the lower limb, they are more desaturated,
Okay,
whereas
the lower
venous blood from the abdominal viscera that is less desaturated. The
okay. What
oxygen
is
saturation is high.
which is the venous blood which is most saturated?
The kidney, from kidney.
Kidney, renal veins. Renal veins have the most saturated blood. So, in an exerting baby, the lower limb venous return has got more desaturated, significantly more desaturated compared to the intra-abdominal venous return. And hence, by squatting, the lower limb venous return is cut off, and the intra-abdominal venous return increases because of the pressure on the abdomen. Intra-abdominal pressure goes up, and the venous return increases. So the blood in the right atrium becomes more oxygenated. Okay. So when the blood in the right atrium becomes more oxygenated, how is it going to benefit the cyanosis or desaturation? The right atrial blood is more oxygenated blood is coming to right atrium. So what is the benefit?
As a result of which, sir, because of the squatting, there is more blood flow left to right, sir.
There will be increasing peripheral vascular resistance, which shunt the blood from left to right.
And blood from left to right.
So increasing peripheral vasculature makes the blood flow to left to right. So there will be
Actually, it does not become left to right. The right to left shunt becomes much less. So that is what I'm very unlikely that in a pathology of fellow or in a significant VST-PS situation where there is cyanosis, the blood flow can become left to right, but whatever is the right to left shunt becomes much less. So there is reduced. Two things happen. One, as you rightly said, the second mechanism is because of the squatting, the arterial system in the lower limb is actually squeezed, resulting in increase in the peripheral vascular resistance. Increase in the peripheral vascular resistance actually increases the systemic blood pressure, and the right to left shunt significantly comes down. So when the peripheral resistance increases, the right to left shunt significantly comes down. In a very mild pathology of fellow, actually if there is a squatting, sometimes the shunt can become left to right, but very unlikely that it becomes left to right. Mostly the right to left shunt significantly comes down. Second thing, when more oxygenated blood is coming to the right atrium because of the cutoff of the blood from the lower limbs, while the veins from the abdomen, which are squeezed and venous return is increased, will result in more oxygenated blood in the right atrium. And even if there is a right left shunt, the decrease in the oxygen saturation, the systemic blood is comparatively much less, because whatever is the blood is being shunted from right to left is more oxygenated. So because of these two mechanisms, the oxygen saturation in the systemic blood significantly goes up. The blood which is going to the brain also significantly oxygenated, and the child immediately gets the relief of the breathlessness. So squatting episode significantly reduces the cyanosis by two mechanisms. One, increase in the peripheral vascular resistance, thereby reducing the right left shunt. Two, increase in the venous return from the abdomen, resulting in more oxygenated blood reaching the right atrium, and consequently, whatever is the right left shunt, that will result in the oxygen saturation in the lower limb, in the arterial blood being less affected by the right left shunt, because the blood in the right atrium is more oxygenated. So that is how the children the squatting gives a relief. Okay. So third point is that since the child is having cyanosis, did the parents show the child to a doctor, and what was the advice given by the doctor? So it's very important for us to know whether the doctor examined the patient, said that there is some cyanosis, and also whether the doctor said that this is a treatable condition, may require surgical treatment, whether any such an advice was given to the parents. Ronak?
Sir, sir, as the patient coming from very low socioeconomic status and patient used to live far away from the city area, they used to show nearby local, not a doctor like a Vaid, and they never came to the city side till date
Okay.
before the last episode has occurred.
Okay, so that you should mention that the patient was never shown to a qualified doctor, and
Mm.
they were taking treatment from a local, maybe unqualified Vaidya, and
Mm.
hence regarding the nature of the illness, no information is available from an expert. She can mention that. So this
Okay.
the child. So that, because see, if the child had a disease which is surgically treatable, and if it was the child was shown to a pediatrician, then the pediatrician will definitely tell that the child should be shown to a cardiologist, and proper investigation should be done. And if possible, a surgical treatment can completely relieve the baby of the bluish discoloration. So all those things, those information will be available to us. So we must always ask the parents whether this baby was shown to any qualified doctor, and what was the opinion given by the, or the advice given by the doctor. That also is a very important part. And also you must always ask whether the child was what are the medicines given to the child, if it was given to, if the child was shown to a qualified doctor, whether drugs which can actually increase the urine output, or whether no medicines were advised. So all those things should be asked so that the history becomes complete. Okay,
Okay.
now let us listen to the discussion by Saroj. Saroj,
Yes,
now
yes,
you
sir.
mentioned how can the another mechanism by which the one of the mechanisms by which the squatting can come down is that when the patients develop more and more aortopulmonary communications. When the aortopulmonary communications become more and more, the blood flow to the pulmonary system becomes more and more, and that will result in less of cyanosis, less of squatting, and squatting may completely disappear. So it indirectly indicates that more and more blood is reaching the pulmonary system. Okay, so here the squatting is continued even at this age. So we don't have any clue that whether the actual there is an increase in the pulmonary vascular system, pulmonary blood flow. So the development of large aortopulmonary collaterals is one reason for the reduction in frequency, as well as the even disappearance of the squatting episodes. Okay, right. Okay, Saroj, right, go ahead. No, don't let us discuss the story. Saroj,
Yes, sir.
discuss the story and come to a conclusion.
So, from the history, it looks that mm, a 10-year-old baby
Hmm.
started the symptomatic first as a cyanosis at the
Hmm.
age of around 6 months.
Okay, so you can say that
This
the child is having a delayed recognition of cyanosis, that it's delayed.
delayed, yes, sir. Uh,
So what are the conditions in which the cyanosis is detected delayed?
uh, the first that either the observational power of the parents were not correct.
Hmm.
Then, sir, and number two, sir, the black mm, uh, sir, black race, and so it may not be detected.
How do
Also,
you, how do you know it's a black race?
uh,
How do
so
you know that?
no, sir, I am not telling in this case
Hmm.
that sir, may not be, sir, because
Oh, okay. In a people with a dark skin, sometimes detection of cyanosis may be delayed. I agree with you. Okay, right. Yes.
and sometimes sir, the
When you
cyanosis
say
is
dark race and all, you can say that in dark skinned people,
yes,
the
sir, yes,
recognition of cyanosis can be delayed. Yes.
yes. And sir, sometimes the cyanosis is too mild to be detected by the parents, and
Yes.
sir,
Yes.
by doctors, sir, it may be detected. Sir,
Yes.
usually, sir, parents detect when it is less than 85%, whereas sir, physician even can detect around 90% or less. Sir.
Usually, when the cyanosis is there detectable, it is near about 85%. Usually, that is the pattern.
Yes, sir.
Even though it is described that below 90 it can be recognized, but very often the recognition is only 85%, and parents detected when it is fallen to around 80%. Okay, so but whenever you are saying that the child has detected delayed cyanosis, I think you should discuss a possibility of VSD.
Pulmonary stenosis
Yes,
situation.
VSD-PS situation. The Tetralogy of Fallot is the best example, where the children may not have cyanosis at birth and may develop cyanosis by 2 to 3 months.
Yes, sir.
So that is something which you can always keep in mind. When there is a delayed cyanosis, always think of the possibility of tetralogy.
VSD physiology and the
VSD-PS
differential
physiology.
diagnosis. Yeah.
Tetralogy failure being the commonest condition where there is a VSD-PS situation. Okay, that has to be. Is there any point which is against tetralogy failure? Is it a high flow situation or a low flow situation?
It is a low flow situation.
Why do you say that?
Uh, So because there is they deny that there is during feeding there is no shortness of breath. So there is
Before,
cyanosis.
before you can say the positive findings, that this patient is having episodes of sweating. And
It's sweating.
squatting
Yes.
is, VSD-PS with low flow. In patients with low flow VSD-PS, the squatting is an important symptom. While if it is a high flow situation, the more important symptom is recurrent respiratory tract infection,
And
features of,
sweating during feeding.
features of heart failure. They
And
suck the breast, then release it, suck the breast, release it. So,
suck phenomena.
yeah, stop suck phenomenon. So that is not there. So in this patient, because of the story of squatting, I would definitely think that the child is having a low flow situation, and VSD-PS is most likely. Okay, right. What else? Do you think it is pulmonary atresia?
Sir, pulmonary atresia is a severe phenomenon of the top physiology,
Okay.
and usually patient presenting with severe cyanosis or sometimes required medical urgency, or maybe sometime presenting with cyanotic spell as well.
So pulmonary atresia, cyanotic spells are much less frequent compared to in patients with VSD-PS situation.
Yes.
Because but these patients can still have squatting. Why do these patients squat? Why do these patients squat? How can the squatting give some relief to the patients with pulmonary atresia? So let us look at the hemodynamic changes of squatting. One is increase in the venous return with more oxygenated blood. Is it beneficial for patients with pulmonary atresia also?
Yes, sir.
Yes, because even when there is a right and left shunt, the desaturation of the systemic blood flow will be much less because of the blood coming to the right side is more oxygenated. Two, can the in patients with pulmonary atresia squatting increase the pulmonary blood flow?
No, sir. Not
Why?
significantly.
Why not? Saroj or anybody else? Gaurav, anybody who would like to give an opinion?
Yes, sir. It can increase by the either by the collaterals or the PDA which is present. Sir.
Yeah, PDA may not be very significant contribution, but collateral flow. The collateral flow can significantly increase, and that will result in improved pulmonary blood flow.
Blood flow.
Why is it that PDA in patients with pulmonary atresia is very insignificant? Ronak?
As there is a less pulmonary blood flow, so less pulmonary blood flow that communicate with the systemic circulation.
Yeah.
So there is no major role of PDA.
Okay. So PDA is required when the blood comes through the pulmonary artery, and since the lungs are not expanded, there is no point in the blood flowing the arterial system to the pulmonary arteries. So it is short circuited or shunted to the systemic circulation through the ductus arteriosus. In a patient with pulmonary atresia, very little, practically no blood is flowing from the right ventricle into the pulmonary arterial system. And whatever is blood in the pulmonary artery system is the venous drainage coming from the collapsed lungs and all this, very little blood. And so the function of the PDA is practically very little, and the PDA in a patient with pulmonary atresia is actually elongated and narrow, and it has got very little function. So in a patient with pulmonary atresia, the ductus arteriosus will be a very insignificant structure with a narrow, which is quite narrow and maybe elongated, but it is very insignificant. Okay, the pulmonary artery receives the blood mostly through the aorta pulmonary collaterals. Okay, right, yes. So if there was a story that the patient was examined by a pediatrician and no heart disease was mentioned, then I would have thought that the child is not having any murmur and pulmonary atresia would have been a possibility. But here we don't have a definite story whether the child was really seen by a pediatrician or not. Okay, right. Okay, Saroj, any other condition? So you are thinking one tetralogy of fellow because in general, I would advise that if the patient is having a cyanosis and if the child is more than 2 years, how many percentage are tetralogy of fellow?
Sir, around 30 to 40% of the.
No, previous teaching was about 75%, 3/4 cases above the age of 2 years, because the large bulk of patients with transpositional great arteries, which forms the other major cyanotic congenital heart disease, usually die within 1 year, because when the studies were conducted, there was no facility to operate upon these patients. So if a child is more than 2 years of age, about 75 to 80% of the cases it should be. No, not 75. You're right. About 1/3 to half will be tetralogy of fellow.
Yes.
And when the child is more than 6 years,
more than
about
6
years, about half to 2/3 will be tetralogy of fellow. If the child is more than 10 years, then 10 to 12 years, then usually about 3/4 of the cases will be tetralogy of fellow.
Yeah.
So as the age of the baby increases, and you think that this is a low flow situation, the possibility of it being a tetralogy fellow steadily increases. Though this child is 10 years of age, so the chance wise, by the evidence of statistical evidence, the lesion should be a VSDPS tetralogy fellow. Right. Anything else, Saroj, would you like to discuss? Any other condition that crosses your mind? Can this be transposition with the VSDPS? Saroj, what is your comment?
So transposition with VSDPS.
Sir, it could be.
Yeah, okay, yes.
It could be CCTG with VSDPS, but transposition physiology less likely to survive beyond 1 year.
Okay. No, VSDPS sometimes can survive, but in them also the survival is very, very low. And also that usually these babies are significantly cyanosed at birth, so that anybody can easily detect a cyanosis. So the absence of cyanosis detection till the age of around 6 months or so, I think makes the possibility of transmission of great arteries with VSDPS unlikely. Do you think this can be Epstein's anomaly? Ronak, what is your comment?
Sir, it could be.
No, don't say could be and all. If you are in your mind, if you think that is very unlikely, you should say very unlikely.
Okay.
Don't think that even if the examiner asks you a question, don't immediately fall to it.
Sir, there is biphasic cyanosis in Epstein, sir.
Okay.
There are two models. First, cyanosis appears, then it disappears, and then again it reappears. The history is not suggestive of that, sir.
Okay. And also, is the squatting an important symptom of Epstein's anomaly?
No, squatting usually is not in the natural history of Epstein.
Not usually, never. Because squatting mostly insert occurs in a patient with VSDPS, thereby, and squatting thereby improves the blood flow to the pulmonary system. So, history of squatting, then the pattern of cyanosis, all are against the diagnosis of Epstein's anomaly. So, Epstein's anomaly is very, very unlikely. Do you think that is, Ronak, do you think that is truncus arteriosus?
Sir, no, sir. Truncus arteriosus is less likely because it's a high blood flow situation. Truncus arteriosus is
Very good. It's a high blood flow situation, and there is nothing in the story to suspect that it's a high flow situation. And two, usually truncus arteriosus patients, if they are not operated, most of them die before the age of 1.
Yeah.
So it's very unlikely that it is truncus arteriosus. Any other condition that you would like to? Do you think that this could be just a pulmonary arteriovenous fistula? Ronak?
Mostly, sir, pulmonary AV fistula remain asymptomatic, but cyanosis is there. But
Okay.
patient do not have any major symptoms except if it is a major hemoptysis or like that.
Okay.
Otherwise, patient remain asymptomatic.
Squatting?
Usually,
Squatting is not common in AV fistula, and sir, it is
Don't use the words not common and all. Why are you saying that not common?
it is not common.
Squatting is not a feature of
AV fistula, sir.
you should make that a very bold statement.
And cyanosis is marked.
Yeah, cyanosis depends upon how much is the AV fistula's communication. If it is a relatively large AV fistula, then the patient would be deeply cyanosed. Depends upon the fistula's tract. So I think all probability we should think that this child must be having VSDPS physiology, and most likely it could be tetralogy of Fallot. Most likely it could be tetralogy of Fallot. Okay, right. Now we'll go to any other point anybody like to discuss.
The single ventricle.
Single ventricle is a possibility. We can only thing is that single ventricle usually is associated with most of the patients with single ventricle are associated with transposition, and they usually will be more cyanosed.
No, sir.
There are cyanosis. It's a admixture lesion, and cyanosis will be present from
But
birth. It's admixture lesion, so it will be present from birth. So we're relying on the story that the cyanosis was first noticed by the parents only by the age around 6 months or later. I think the single ventricle possibility is unlikely.
the survival is good. That's
It depends upon VSTPS.
sir, in single ventricle also. So
In
it is
single ventricle, you need a VSTPS physiology.
VSD.
See, whenever there is a survival beyond the age of 6, I think you must always think of the possibility of VSTPS physiology, because it is the VSTPS that protects the child and allow the baby to thrive, baby to grow, and survival beyond 6 years, 10 years without any intervention. Most likely it will be VSTPS. Okay, right. Yes, now coming to physical findings. Any other point anybody would like to raise or discuss? Others, Gaurav, I didn't hear him. Is he around there? Gaurav Pandey, are you around there? I didn't hear any discussion from him. Okay, right, yes. Okay, go ahead. You can, Ronak, let us get your discussion. Yes?
yes, sir.
Okay, now coming to physical findings. And
Patient is conscious, oriented to time, place, and person, moderately built, poorly nourished. Weight is 20 kg, height is 125 centimeter. There is central cyanosis present, pen digital grade 3 clubbing present. There is no pallor, icterus, or edema fit.
one thing I want to ask you, Ronak, do you think that this is Eisenmenger physiology?
Eisenmenger's physiology usually develop in pre-tricuspid or post-tricuspid shunt physiology, and they are a increased pulmonary blood flow physiology. So
Okay.
initially, patients should have some symptoms of increased pulmonary blood like dyspnea or recurrent recurrent respiratory tract infection, and usual and another that recurrent infection, and along with that the Eisenmenger is usually early in truncus arteriosus, it usually
Truncus arteriosus. Why did you go to truncus arteriosus in Eisenmenger physiology?
means sorry sir, the Eisenmenger will develop in VSD and PDA as per the natural history. It's around in adolescent age group, around 20 to around 18 to 20 years of the age group.
In the second decade, maybe in the second half of the
second half of the decade.
Okay. You said about this recurrent respiratory tract infection, all those things. Is it
Yes,
common to have recurrent respiratory tract infection in ASD?
no, yes, sir. In ASD, it is common, sir.
No, not usual. What is the mechanism of recurrent respiratory tract infection?
Sir, due to increase in pulmonary blood flow,
Yes.
the that will causes the stasis of that increased blood flow causes stasis in the stasis, and they causes uh, goblet cell to secrete more. Uh, uh, Actually, I'm
So,
not.
sir, there is mucus plug formation is there, which
Oh.
causes.
The two things are there. Three things are usually the recurrent respiratory. Saroj, what is your comment about the reason for recurrent respiratory tract infection?
Sir,
Mostly-
yes, sir.
Anybody else who would like to give a comment?
Sir, in case of VSD and PDA, the patient gets more respiratory tract infection than the ASD because sir, in case of this post-tricuspid, the patient also have a pulmonary venous hypertension together with pulmonary arterial increased blood flow.
No, you see, recurrent respiratory tract infection has got two mechanisms. One is Aditya, we give your comments.
So it's because of increased mucus production and stasis of blood, which causes the source of microorganism to stay there, leading to the increased infection in the lungs.
Yeah, one is that because of the increase, most important reason is that when there is increased pulmonary blood flow, that will result in pulmonary congestion, because these patients with VSD and PDA can develop left ventricular failure. And when they develop left ventricular failure, it will result in edema of the bronchial tree, the increased bronchial secretion, and also the cilia of the globular cells of the lining membrane of the trachea and the bronchi fail to move. Usually they are moving outwards, and thereby the infecting organisms which are coming to the lung is pushed back from entering the lungs. Once the cilia, even though it is very minor, when the cilia stops functioning, that will result in the easy entry of the infecting agent into the lungs, giving rise to lower respiratory tract infection. Second is the heart failure. When the patients develop heart failure, there is always a risk of developing recurrent respiratory tract infection. So recurrent respiratory tract infection is due to two mechanisms. One, development of heart failure. Second, the edema of the mucous membrane resulting in mucus plugs, and the movement of the cilia of the globular cells comes down, resulting in more easy entry of the infecting agent into the lungs. But in a patient with ASD, they do not. It is a pre-tricuspid shunt, and these patients do not develop left heart failure. So in patients with the ASD, the recurrent respiratory tract infection is not a very important feature. They can develop bronchitis, but much less frequent compared to what is happening in a patient with VSD with PDA. So you should know that VSD PDA can give us much more frequent respiratory tract infection compared to ASD, where in ASD patient the LV is spared, and hence the chances of pulmonary congestion and recurrent respiratory tract infection is significantly less.
Sir, in ASD, RA and RV are also compliant. That's why, sir, less.
That is the reason why there is a left-right shunt. When the RV becomes compliant, the left-right shunt in a patient with ASD is decided by the compliance of the right ventricle. When the right ventricle becomes more and more compliant, the more and more blood will be shunted from left atrium to right atrium to right ventricle, and the shunt becomes more and more. Okay, right. So in this patient, the Eisenmenger is very unlikely. Not unlikely, it cannot be considered because of the the pattern of the story. One is the history of squatting, which is not a feature of Eisenmenger. Two, in Eisenmenger, what is the pattern of symptoms of a patient? Patient with a VSD PDA is progressively developing Eisenmenger. Can Ronak describe the pattern of the symptom?
Sir, during childhood, patient have feeding difficulty, then hyperdynamic chest, then patient have suck race suck phenomenon, then history of recurrent respiratory tract
Okay,
infection,
all features of increased pulmonary blood flow.
pulmonary blood flow.
Okay, then what happens over a period of another 5 to 6 years?
So in VHD and PDA, there is early start of pulmonary hypertension, and which was progressed to over a period of years, and the RV pressure, right ventricular pulmonary artery pressure, gradually becoming gradually increases gradually increases, and uh, uh, and in,
What will happen to system of the symptoms of the patient when the patient grows from
usually, sir, as the pulmonary artery pressure increases, there is a reduction of the left to right, and patient becomes gradually improving in symptoms.
asymptomatic. We should say that
Asymptomatic.
in a patient with VST and PDA, as the patient develops pulmonary arterial pressure rise, pulmonary arterial hypertension, the left to right shunt significantly becomes less, and the child will become almost asymptomatic.
Asymptomatic.
That is something happen. That is something very unfortunate can happen to parents of babies from low socioeconomic status. Finding that the child has become less symptomatic, they will start thinking that the child is completely cured of the disease. That's the problem. And then what happens?
Then in second decade of life, patient became gradually start with exertional dyspnea, which was initially it was NYHA class 2, and then it was progressed to NYHA class 3, and there is a pulmonary artery pressure gradually become equalized to the pressure of systemic pressure, and there is a bidirectional shunt.
Okay. Now, what you need not describe all these things. You should say that initially the child is significantly symptomatic because of the large left to right shunt and presence of left ventricular failure. And over a period of time, the child is gradually develops pulmonary arterial hypertension, and the left to right shunt becomes less, and the child becomes less symptomatic, and sometimes may become practically asymptomatic. And when the pulmonary artery pressure vascular resistance further rises, that will result in bidirectional shunt or maybe a dominant right left shunt, and the child becomes cyanosed and becomes again symptomatic. So initially symptom, then the symptom comes down and become asymptomatic, and the child becomes symptomatic again. So that is the pattern of patients who develop Eisenmenger syndrome in a patient with VSD with PDA. Here there is no story like that, so possibility of an Eisenmenger syndrome is practically ruled out. Okay, right. Yes, go ahead.
Sir, there is a doubt, like why patient with Eisenmenger have or pulmonary artery hypertension have hemoptysis. So what is the mechanism behind it?
Saroj?
Yes, sir. Sir, in case of Eisenmenger, so there is a increase in the pulmonary venous hypertension.
One minute, Saroj.
No, sir.
Okay, now go ahead. Yes.
So because of the increased blood flow, the increased viscosity is there. So, sir,
Sir, initially it is due to rupture of the bronchial arteries when there is increased pulmonary blood flow. And when it gets Eisenmengerized, then The hemoptysis can be due to pulmonary infarction.
No, see, can anybody describe to me the vascular changes of Eisenmenger? Grade 1, grade 2, grade 3, grade 4, vascular changes of Eisenmenger. Pulmonary arterial vascular changes. What is the grade 1 change?
Heath Edward classification.
Heath Edward classification. Heath Edward actually has got 6 stages, but now the 4, 5, 6 have been clubbed together and made it 4. So what is the grade 1 change, grade 2 change, grade 3, grade 4?
The one is medial hypertrophy.
Very good. What is your name?
Dr. Sriram.
Sriram, very good. Yes, a medial hypertrophy. Grade 2.
Then it progress. Intima is involved, sir.
Yes, intimal
Intimal
hyperplasia. Very good. Intimal hyperplasia. Grade 3.
Then it further progress and cause intimal occlusion. Intimal occlusion.
Intimal fibrosis.
Fibrosis and occlusion.
Fibrosis takes place and there can be occlusion. Grade 4.
Sir, then it involves there is progressive dilatation of arteries.
Arterial changes, arterial and the changes occur, resulting in plexiform malformation, clots in the arterial system, aneurysm formation. All these things happen, and all these things can rupture and can give rise to hemoptysis. So patients with Eisenmenger syndrome, once they have developed stage 4 of the pulmonary arterial changes, which involves the plexiform malformations, thrombi, aneurysm formation, all this can result in rupture of these plexiform malformation, rupture of the small microaneurysms. All those can rupture and can give rise to hemoptysis. Very often it is precipitated by a respiratory infection. When there is a respiratory infection, the rupture can take place and that can result in hemoptysis. Is that clear to you, Ronak?
Yes, sir. Yes, sir.
It is because of the stage 4 pathological changes of the Eisenmenger syndrome. Okay, right. Yes. Usually it is precipitated by respiratory infection. There is something to precipitate it, and of course it can happen without also, but most of the times it is a respiratory infection which precipitates hemoptysis. Similarly, hemoptysis can occur in tetralogy of Fallot. What is the mechanism?
Pulmonary infarction, decreased flow.
Collateral rupture.
Collateral rupture.
Yes,
rupture.
It is not infarction. It is infarction. Yes, microinfarcts can occur in Eisenmenger syndrome, but they are very uncommon in tetralogy of Fallot. Tetralogy of Fallot, it is because of the rupture of the large collateral. Some of the collateral flows which is coming to a lung can actually rupture. The pulmonary vasculature can rupture because of the high pressure, and that can result in hemoptysis. Hemoptysis can occur in tetralogy of Fallot also. Okay, right. Yes. Okay, right. Go ahead, Ronak. Any other doubts? Anybody that you can raise it? Okay, go ahead.
Sir, temperature normal by palpation. Pulse 104 beats per minute, regular in rhythm. No radio or radiofemoral delay. Blood pressure is 100 by 70 millimeter of Hg on both upper limbs. Respiratory rate is 29 breaths per minute. Sir, this is wrong. It's falsely mentioned, sir. JVP.
No, I want to know your respiratory rate is 29. What is the normal respiratory rate?
Sir, normal respiratory rate is around 16 to 18 breaths per minute.
In adult, it is 12 to 14, not 16 to 18. 16. Baby may be slightly more, but in an adult, 10, 12 years, you will reach the adult stage, and usually the respiratory rate of an adult is 12 to 14.
12 to 14.
Here it is definitely high.
Yes.
Heart rate also is high.
Yes.
Temperature is slightly degree 400.
Temperature I have mentioned wrongly, sir. That was.
No, temperature normal by palpation, that is all right. But when you took, you see, 99 degree Fahrenheit and not, sometimes you may not be able to detect by palpation.
Okay.
That is all right. You thought that temperature is normal by palpation, but when you took the temperature by thermometer, you found that it is 99 degrees. Nothing to be worried about it, because if it was 104 and then you said by palpation it is normal, then there is a problem.
Okay.
99 degrees, sometimes it may not be, you may find it difficult to pick up by touching the patient. Okay, JVP.
JVP pulsatile with normal A and V wave with normal descent with a mean JVP 2 centimeter above the sternal angle with hepatojugular reflex negative with normal respiratory variation.
What do you mean by hepatojugular reflex negative?
Sir, while there is a pressure is given around 15 to 30, 20 millimeter of Hg pressure is given on the right hypochondrial region or in the epigastric in the
Is there a mention about 20 to 30 millimeters of mercury pressure?
No, sir. No, that is by the definition, sir. It's a theoretical definition.
That
It
I
is
did
not
not
possible.
know.
It is seconds.
It is 20 to 30 seconds pressure, not 20 to 30 millimeters of mercury.
For 10 to 15 seconds, sir.
Around, but see, it means that you had to press for a short period. Usually it is around 15 to 20 seconds. So sustained pressure over the abdomen. Okay, right. That will result in what?
That will result in rise in the JVP for more than initially rise in the JVP and when the if the left ventricle is compliant enough, then it will fall down to become a normal. If it is
left
if it
ventricle is
persistent.
compliant. What do you mean by left ventricle is compliant?
LV is LV function is good. Then the whatever the increase in the venous return has been accommodated by the left ventricle in a
venous return, systemic venous return is accommodated by the left ventricle.
Initially, it is accommodated by right ventricle, but as soon as it enter into the systemic circulation, initially left ventricle.
No, please describe the hepatojugular reflex. Then only it will be correct. What is hepatojugular reflex? You describe it. When there is when you press over the abdomen, what happens?
Venous return is increased.
Yes. Venous return through which vein?
With through portal and hepatic vein that joins the inferior vena cava, and from inferior vena cava to R.
The IVC venous return is increased. It is mostly because of the intra-abdominal pressure increase, and it is not a must that you should press over the liver area. Even pressure anywhere in the abdomen is enough. That is why most of the people think that it should be renamed as abdominojugular reflex. So it is being named as hepatojugular reflex. That's fine. Pressure over the abdomen near about the liver area will result in compression of the abdominal veins, resulting in increase in the venous return through the IVC. Okay.
IVC.
Then what happens?
So that will be reflect into the reflect to the internal jugular vein. So transiently, it shows that transiently there is increase in the JVP, and that increase venous return travel through the pulmonary circulation, and then
no, you don't have to tell all those things. No, not at all. Anybody who would like to explain, Saroj, or somebody?
Yes, it rise to the 3 centimeter and up to 15 seconds it is normal, and it will come down.
I don't
10
know.
to 15 seconds only.
Yeah, I know it's about up to 5 to 10 seconds.
More than 15 seconds, it means the patient is in incipient right ventricular failure.
Yes, that is our evidence. When you compress the abdomen, it will result in increase in the venous return through the IVC. And when the sudden increase in the venous return through the IVC will reflect into the superior vena cava, and that will result in a transient rise in the internal jugular venous pressure, and which will immediately settle down within 10 seconds. Usually, at the most, it may remain for 5 to 10 seconds, but it will immediately settle down. But if it does not settle down and it persists, that indicate incipient right heart failure. It is not the left heart failure.
In this patient, sir, we should not do, because sir, IVS is not intact. So, sir, this hepatojugular reflex is not relevant in this case.
Yeah, no, but if somebody has done a hepatojugular reflex, that's fine. But I agree with you that when there is a large ventricular septal defect, hepatojugular reflex may not be very relevant. I agree with you. Or if there is a large ASD, all those things. But doing a reflex is not a problem. And also, if the patient is having an intact intrathecal septum, there is a possibility that still you will be able to elicit a hepatojugular reflex, even in patients with with a large VST. So there is no harm in doing the reflex, but that's not a, that is not a, so here he has said that there is a negative hepatojugular reflex. So what is the explanation? Ronak, negative hepatojugular reflex.
It means that RV and RA are compliant.
It may mean that RA and RV are compliant. In a tetralogy fellow, do you think that RV will be compliant or less compliant?
Less
Sir, RV
compliant.
is less compliant because of
Hypertrophy. But more important is that the hepatojugular reflex may be absent if there is a large ASD. If there is an ASD, the hepatojugular reflex may be may not be there, because as the venous return to the right atrium increases, that will be actually shared by the right atrium and the left atrium, and that may result in absent hepatojugular reflex. Second reason for hepatojugular reflex is if there is a superior vena cava obstruction. When there is a superior vena cava obstruction, then the reflected the increase in the IVC and the increase in the venous return to right atrium cannot reflect onto the internal jugular vein, and it may be absent. So when you are saying that there is no hepatojugular reflex, you are indirectly saying that either there is an obstruction to the superior vena cava, or you are saying that there is a most likely there may be a large AST or maybe single atrium, or maybe the thing. Okay, right? Yes. Go ahead, Ronak. And what is the pattern of JVP in a patient with tetralogy fellow? Ronak?
Sir, it is normal, sir.
Normal. It's not usually elevated. But can it be elevated?
Yes, sir.
What is the reason why the JVP is not elevated in a tetralogy fellow? Why it is not elevated?
Sir, because
why it is not elevated? What is
So
the what is the yes.
Get VSD can cause decompression of
Yes. The increase in the jugular venous pressure is as a result of an increase in right atrial pressure. And in the presence of a normal tricuspid valve, the right atrial pressure elevation is depending upon the right ventricular diastolic pressure. So if the right ventricular diastolic pressure increases, that will reflect onto the right atrium, and that will reflect onto the jugular venous pressure. But in a patient with the VSD, what happens when the right ventricular diastolic pressure increases, it can get decompressed onto the left ventricle. And hence the RV diastolic pressure, even though RV is hypertrophied, the elevation of the right ventricular pressure is not a feature of tetralogy fellow. And hence, usually JVP is not elevated in tetralogy fellow. But there can be certain situations where JVP can be elevated in tetralogy fellow. And what are the situations which can result in JVP elevation in tetralogy fellow?
Sir, when there is a RV pressure is suprasystemic, like Hoffman phenomenon.
How can there be suprasystemic RV pressure?
When there is a restrictive VSD, there is a restrictive VSD there.
Oh, usually the tetralogy fellow will have a
non-restricted.
In tetralogy fellow, you cannot get a suprasystemic RV pressure.
There is Hoffman variation.
Well, I do not know whether it can be really possible, because usually the VSD of tetralogy fellow is usually non-restrictive, huge. Because what is the developmental anomaly of the tetralogy fellow?
Sir, malalignment of the infundibulary septum.
Yes, yes. So because of that, the septum cannot grow into the muscular part of the VSD, and that will result in a huge ventricular septal defect. It should be unlikely. I'm not certain whether some cases are reported where there can be suprasystemic, but not to my knowledge, because the VSD is so huge that suprasystemic pressure is not possible in the right ventricle. Second is the people have described that there can be sometimes JVP elevation in tetralogy fellow. And what is the mechanism? Any one of you?
MAP.
Sir,
RV dysfunction or MAPCAS, if very
yes,
prominent.
sir, in
RV dysfunction, or in patient adult
adult of with the LV dysfunction.
LV dysfunction, especially with aortic regurgitation.
MAPCAS, sir. MAPCAS, if it is there.
Yes, the large pulmonary large flow coming to the left ventricle can sometimes give rise to JVP elevation, because the LV diastolic pressure can go up. 3.
So associated with TR or any post of BT shunt, sir.
TR can have most of the patients with tetralogy fellow when you ultimately will have some degree of TR. Another mechanism described is that sometimes there can be partial closure of the VSD by what?
Tricuspid
leaflet.
Septal leaflet of the tricuspid valve, and that can make the VSD restrictive during diastolic phase, and that can result in sometimes JVP elevation. So there are 3 mechanisms are described. One, in an adult when there is aortic regurgitation, LV dysfunction. 2, in a younger patient where there is a large MAPCA, large major pulmonary artery, aorta pulmonary collaterals being very huge ones. And 3, patients in patients where the tricuspid septal leaflet to the tricuspid valve can partially close the VSD, that can also result in JVP elevation. Okay, and usually you will be able to see A waves. Okay, that's fine. Normally, usually JVP is not elevated in a patient with tetralogy fellow. That is because of the diastolic compression of the RV, because of the large unrestricted ventricular septal defect. Okay, right. Yes. Next. Any point? Any doubts about things which we have already mentioned? Okay, right. Go ahead. Yes, Ronak, go ahead.
Inspection: chest is bilateral symmetrical with a normal precordium. Apex impulse is visible on 4th intercostal, just inside the mid-clavicular line. No other impulse, scar, sinuses, or dilated veins.
So there is no cardiac enlargement. So
No
does that go consistent with the tetralogy fellow?
Yes, sir.
Yes, and also tetralogy fellow will have a very quiet precordium. That's one feature. They usually will have very quiet precordium. There is no cardiac enlargement, and the features up to this stage are quite consistent with the diagnosis of tetralogy fellow. Okay, go ahead next.
Palpation: apex beat is located in left 5th intercostal space, 7 centimeter from mid-sternal line, just medial to mid-clavicular line. Normal in nature. No left parasternal heave, no thrill, no palpable pulmonary component, no epigastric pulsation.
Okay. Any odd points for tetralogy fellow, or you think that these findings are consistent with the tetralogy fellow? Ronak.
Usually,
Usually they have RV type of apex. So.
Need not be. Sometimes apex may be just palpable and it may not have a special character, because usually the RV apex becomes very prominent when it becomes when there is a volume overload. Since this is a pressure overload, the RV size may not be huge, and that may not give rise to any significant. In an AST, you can get an RV apex because it's a volume overload. So here this is a pressure overload, and sometimes the RV may not dilate, may not be hugely dilated to reach the apex. So I think it is not a must. RV apex is not a must. I will not. But if it is LV apex, then it is abnormal. So sometimes, as he has said, he has located the. You are not mentioned about the character of the apex bit. Ronak, you should mention about the character of the apex bit. Is it a LV type, RV type, or just you cannot comment?
Okay.
You must always comment about the type of the apex bit. Okay, right. Go ahead. Next one.
Upper border liver dullness is 5th intercostal, right intercostal space in mid-clavicular line, suggestive of situs solitus. Left border correspond to the apex bit, and right heart border is substernal.
Okay. Right. Okay. Right. Yes. Auscultation.
First heart sound is normal in all areas. Second heart sound is single. There is no ejection click. There is no S3, S4. There is ejection systolic murmur in pulmonary area, radiating to the base, but not to the carotid. Base third with the diaphragm, increase in intensity with breath hold in inspiration. The murmur grading is 3/6. There is no added sound. Lung bass are clear.
Okay, so you have got auscultation. You have found that the second sound is single. Then you have no ejection click. S3, S4, nothing is audible. Okay, right. So your findings, are the findings consistent with the tetralogy fellow, or there is an abnormality?
Yes, sir. Consistent with tetralogy fellow.
Fellow. And how do you assess the severity of tetralogy fellow by clinical examination? What are the points which will tell you that it's a severe tetralogy fellow by clinical examination?
Murmur.
Murmur.
The shorter the murmur, the more severe is the stenosis.
Yes. So, Ronak, you should always mention the length of the murmur.
Okay.
You are not mentioned about anything about the length of the rejection systolic murmur. That's not enough. Whether it is short or long. Why are you saying that? What is the long murmur indicates less cyanosis, and short murmur indicates long murmur indicates severe. Mild tetralogy fellow, and short murmur indicates severe tetralogy fellow. What is the physiology? What is the hemodynamics? What is the hemodynamic change which will tell you that the long murmur indicates less degree of or less severe tetralogy fellow?
Sir, long ejection period. There. So, are we able to? There is no significant RV dysfunction, and are we able to pump the blood through that ejection period time?
Okay. When the obstruction is less, in tetralogy fellow, the severity is decided by the RV outflow obstruction. When the RV outflow obstruction is less, the RV will be able to pump blood from the beginning of the systole till late in the systole, indicating that there is a good pulmonary blood flow. And the pulmonary blood flow and RV outflow obstruction decide the severity of tetralogy fellow. So in a patient with mild tetralogy fellow, more blood will flow to the pulmonary system, and the murmur will be much prolonged. While in a patient with severe tetralogy fellow, where RV outflow obstruction is severe, the murmur will be very short, and that indicates the severe tetralogy fellow. But if there is a disparity in the length of the murmur, what is the condition that you should suspect?
URB, sir.
URB. You should suspect the toxic being anomaly, where the length of the murmur does not tally with the
severity of the
severity. If the patient is having a long murmur, and if the patient is having severe cyanosis, you should start thinking that it is not a tetralogy fellow. Because in a tetralogy fellow patient, if the murmur is long, the cyanosis will be significantly reduced. It will be less. Okay. So the length of the murmur will tell you about the severity of tetralogy fellow. What else? Ronak? What is the other clinical finding which can tell you about the severity of tetralogy fellow? Anybody else? Anybody?
The collateral circulation, sir, murmur, continuous murmur is we can hear.
Continuous murmur. Yeah, okay. Continuous murmur will tell you what?
So, sir, that collaterals are predominant and the RVOT obstruction is significant.
Okay. If there is a collateral flow, that will tell you that most likely that the RVOT obstruction is very significant, and that indicates more severe form of tetralogy fellow. Very good. Third point. Anybody?
Quiet precordium.
Well, usually in tetralogy fellow, precordium is quiet. The precordium will be very active in volume overload conditions. So here, in a tetralogy fellow, usually it is not a volume overload condition, and the precordium will be very quiet. Sometimes you may be able to get mild parasternal lift, but not significant. Okay, right? Yes.
RV type of apex.
No. Anything to do with ejection click?
Sir, if click is present, it will suggest valvular PS and good flow.
The ejection click in a tetralogy of alloy is due to valvular P.
Aortic, sir. It is aortic.
Dilated ascending aorta leading to aortic click.
Yeah, the ejection click in a tetralogy of alloy is due to dilated aorta. So the larger the aorta, smaller the
Pulmonary artery.
pulmonary artery. So more severe the tetralogy of fellow. So the presence of an ejection click is a point in favor of a severe tetralogy of fellow. So a few clinical findings which will help you to assess the severity of tetralogy of fellow by clinical examination is 1, the degree of cyanosis, 2, the length of the ejection systolic murmur, and 3, presence or absence of aortic ejection click. Even though ejection click has been described in with valvular PS also, but the click in tetralogy of fellow is almost always aortic. It is a constant click. Okay, so here there is no click and length of the murmur. Ronak has not described. Ronak, always you should describe the length of the ejection systolic murmur. What is the gradient across the gradient across the RV outflow in patients with the mild, moderate, severe tetralogy of fellow? Ronak?
Sir, gradient remains same, sir.
Gradient. What is your name?
Arun Kumar, sir.
Arun Kumar. Why did you say the gradient remains the same? Then what is changing?
Sir, one day it is because the flow is changing, sir. Because of there's an increase, flow is changing, sir.
Yeah, right. Flow is changing. Very good. So in a patient with tetralogy of fellow, mild, moderate, severe, independently, whatever may be the severity of tetralogy of fellow, the gradient across the RV is the same. Gradient across the RV outflow is the same, and RV pressure is always equal to LV systolic pressure.
Yes,
and when a patient with less severe RV outflow obstruction, the gradient is maintained by increase in the pulmonary blood flow. Increase in the flow. So actually increase in flow along with mild or less severe RV outflow obstruction can have the same gradient as in a patient with severe RV outflow obstruction with lower blood flow. So gradient across a stenosis segment is decided by 2 points. 1, the severity of the obstruction, and 2, the degree of the blood flow. So in a patient with mild tetralogy of fellow, obstruction is less, but the flow is more. In a patient with severe tetralogy of fellow, obstruction is more, but the flow is less. So the gradient across the RV outflow, whether it is mild, moderate, or severe tetralogy of fellow, it is the same. Okay, very good. Anil Kumar, very good. In which institution are you?
Sir, I am from Ramesh Cardiac Center, Vijayawada, sir. Vijayawada.
Okay,
Yes.
good. Are you a final year student or you are?
No, I am in final year, sir.
Final year, okay. I think good. So in a tetralogy of fellow, mild, moderate, severe, it is a gradient across the RV outflow is the same. Okay. All right. Okay. So I think all put together, what is your Ronak? Any other point you want to mention, and then let us come to a diagnosis and let us discuss the other points. Okay. So we'll go to next. Let us go to the next one, Ronak.
Other systemic examination reveals no abnormality.
Okay.
So provisional diagnosis like situs solitus levocardia, congenital cyanotic heart disease with decreased pulmonary blood flow, with a dominant RV, most likely tetralogy of fellow, in normal sinus rhythm without evidence of infective endocarditis, and currently NYG class 3.
Why do you want to make the most likely tetralogy fellow? I would have made
and other differential diagnosis will be DORV with VSD, severe pulmonary stenosis, and VSD-PS physiology.
Okay, this is a VSD-PS physiology, and the commonest VSD-PS physiology is tetralogy. I would have put it as VSD-PS physiology, most likely tetralogy fellow. I agree with you because you cannot be dogmatic about the diagnosis. But if you have looked at the length of the murmur and the length of the murmur and cyanosis are consistent with tetralogy fellow, I would like to put the diagnosis tetralogy fellow. And usually I like the diagnosis as cyanotic congenital heart disease as the first one. But there are others who teach that you should mention about the situs solitus and then levocardia as that's quite fine. But I usually teach cyanotic congenital heart disease, situs solitus, levocardia, because the diagnosis is congenital cyanotic heart disease. That should come out first. So cyanotic congenital heart disease, situs solitus, levocardia, and all those things. Okay, right. Yes. Now coming to the investigations, what investigations would you like to see first? Is it ECG, X-ray? What is the one which you would like to see?
ECG, sir. ECG.
You would like to see ECG first. Why do you want to see ECG first?
For the which ventricle is dominant, like dominance of the ventricle, then rhythm of the patient presenting with dyspnea. So see for the.
Or you are doing in this patient, you are looking at the electrocardiogram to find out the rhythm.
To find out the differential diagnosis of VSD PS physiology.
Okay.
ECG will tell us.
ECG can differentiate the pathology of fallopian double outer right ventricle.
Right ventricle, yes, sir.
How can it differentiate?
Sir, with the help of X-rays, if it is less than 120, right X-ray, less than 120, then it suggests off. And if it is more than 120, then it could be PhD, PS physiology, sir.
Eh? What did you say? I could not follow you at all. What did you say? Please repeat.
Sir, in TOF,
I'll ask two questions to you. In the pathology of fellow, what is the usual axis?
Right axis.
Right axis deviation. In a double outed right ventricle, what is the axis?
It is extreme right axis.
No. Anybody?
Yes. Beyond 150 is the ORV, and usually it is slightly right towards right in TOF. And it is more.
Usually the TOF will have around 120. That's the first point. Double outed right ventricle can also have right axis deviation, but double outed right ventricle can have sometimes abnormal axis, left axis deviation, and also axis in the right upper quadrant. So if you find that it is a left axis deviation and axis in the right upper quadrant, abnormal axis, I think you should think that it is not a pathology of fellow. So right axis deviation is a feature of the fellow. That's one feature. Second is the feature.
So clockwise and counterclockwise rotation, we can differentiate DORV with TOF with ECG.
Yes, very good. What is clockwise? What is counterclockwise? Which one will have clockwise and which one will have counterclockwise?
The TOF will have clockwise rotation while DORV will have anti-clockwise rotation.
Very good. That's excellent. Okay. Another point.
Third, there will be early transition in TOF with RVH and right axis deviation.
Very good. There is an early transition from B1 to B2 is a feature of with RVH with A is a feature of transpose with the tetralogy of fellow. Okay. So now let us look at the electrocardiogram. Ronak, let us look at the electrocardiogram. Okay, you discuss the electrocardiogram. Don't waste time describing minor points. Tell the positive findings.
Sir, sinus rhythm with axis is around
axis around
110, around 100 to 110. Sir.
Oh, it's more than that.
150, sir.
150 because AVR is positive. AVR is positive. So so maybe around lead to maybe equiphasic, and so probably around 150. Okay, right? Yes.
And
is there right atrial overload?
Then lead in P pulmonal tall P wave in lead 2. Then there is a in V1 there is a RV dominance tall R wave is seen. Then in lead V2 there is an early transition of R wave suggestive of large VSD. And there is a ST depression in lead 1 suggestive of right ventricle right RV strain pattern. And are
I say, Ronak, when you communicate, I think it should be very clear cut so that everybody can understand you. So you need not describe all those things. I would say that if I am to describe, I will say that this patient is in normal sinus rhythm. There is a right atrial overload, as evidenced by tall PUS seen in lead 1 as well as in lead 2. There is a axis around 150 right axis deviation, and there is evidence of right ventricular hypertrophy evidenced by R by S ratio in V1 is more than 1. And the other one I am not able to make out, but it seems that there is an early transition. I'm not certain about it. And also in V6 also there is a prominent S wave, R by S, very prominent, indicating right ventricular hypertrophy. So there is a evidence of a right ventricular hypertrophy. What are the, how do you diagnose right ventricular hypertrophy from electrocardiogram? What are the
sir,
three patterns of right ventricular hypertrophy in electrocardiogram?
dominant R wave in lead V1 with ST depression.
The ST depression need not be there. All right. Okay. What are the three types of RVH in the by electrocardiogram? Any one of you?
Sir, very prominent R wave in the V1.
Hmm.
Then, sir, persistent of S state in the V5.
Hmm.
And, sir, one more, three types are there.
Yes. So one is the, see, one is the, anybody would like to give a comment about the right ventricular hypertrophy pattern? Right ventricular.
Sir, R in V1 plus S in V6 more than 11 is, and R in V1 more than.
So one pattern is the systemic pressure overload, volume overload. Other pattern is which is seen in COPD.
Three patterns are described. All the three patterns will have right axis deviation. The R in the pattern in V1 can be QR pattern or pure R or R by S ratio more than 1, which indicates right ventricular hypertrophy, mostly pressure overload. If the patient is having R dash pattern with R dash wave being equal to or more than 15 millimeters or the R wave being equal to or more than 7 millimeters, indicate volume overload. And the third one is where there is a QR pattern, RS pattern from V1 to V6, while in V6 R by S ratio is less than 1. And this pattern usually occurs in what condition?
The COPD.
COPD, very good, COPD. So the three right ventricular hypertrophy patterns, one is pressure overload can occur in pulmonary arterial hypertension and in pulmonary stenosis. Volume overload classically occurs in atrial septal defect, and R by S, small r deepest pattern from V1 to V6, and V6 is having R by S ratio less than 1 in occurs in COPD patients. So there are three patterns of right ventricular hypertrophy, which is very simple to understand. There are complex descriptions, but you must always understand simple ones so that it can apply in your clinical practice. So here, the presence of a
sir, can you repeat once more, sir? These three patterns, sir.
One, all patients will have right axis deviation. All three. Okay, that's first point. They wish all patients with the right ventricular hypertrophy will have right axis deviation. Then second, pressure overload pattern, which is they can have QR pattern in V1 or pure only R wave pattern or R by S ratio more than 1 in V1. This usually occurs in patients with pressure overload. And if the patient is having QR pattern with STT changes, which is suggestive of severe pulmonary arterial hypertension, even suprasystemic pulmonary arterial pressure. 2, volume overload. Volume overload is associated with right axis deviation and RSR dash pattern. Either the R should be more equal to or more than 7 millimeters, or R dash should be equal to or more than 15 millimeters. And it may be associated with STT changes and usually occurs in volume overload conditions like atrial septal defect. Third, patients can have a R's pattern from V1 to V6, and R by S ratio in V6 is more than 1, less than 1, and is classically seen in patients with COPD. So these are the three patterns of right ventricular hypertrophy pattern by electrocardiogram. And is it clear to you?
Yes, sir.
Any doubt you can ask me. Okay.
No. Thank you, sir.
Right. Okay. And Ronak, do you think that the ECG is consistent with your tetralogy fellow, or you would like to consider a possibility of double outer right ventricle also?
Sir, uh, uh, as per the ECG findings, sir, double outlet right ventricle is more likely than.
You think it is more likely. What about others? Opinion of others like Arun Kumar and Anil Kumar and others?
Here is clockwise, no, sir?
Yeah, it is
It's
clockwise.
not clockwise. Yes, sir.
It is
That goes against RV, DORV, sir.
Okay. From the electrocardiogram, it's a clockwise, and I would try to favor a diagnosis of tetralogy of fellow. And also, as Ronak has rightly said, there is a transition, a significant transition from E1 to V2. What is the mechanism of this transition, Ronak?
Sir, large VSD, so there is a septal, there is a pressure transition between LV and RV at the level of the septum. So that is the
Pressure transmission. Why do you want to correlate with electrocardiogram? Pressure transmission.
no.
What is the mechanism of early transition from V1 to V2?
Due to presence of large VSD, so there is no electrical this one in.
Yeah, see, because of the large VSD, there is an electrical activity there, so that will result in absence of septal activity, and that will result in early transition is due to the large VSD. Large VSD is supposed to be the reason for early transition from V1 to V2. Okay, so what about the okay?
Sir, how to identify clockwise and anti-clockwise in this, sir?
Oh, that will be that I have to draw and show you.
Okay, sir.
I think if you want to have an electrocardiogram,
Here,
how
in
to
this
look at the
patient,
clockwise and
there
anti-clockwise.
is a Q waves in the lead to.
You have to find out here. There is a
Sir,
smooth
presence of Q wave in lead 2 and 3 and AVF. Small Q wave in lead 2 and lead 3 side here. Like if you have Q wave in lead 2, 3 AVF, this goes to clockwise. If Q wave in lead 1 and AVL and lead 5, 6, it favors anti-clockwise.
Sir, actually, sir, there are two things, clockwise and counterclockwise loop, which just now Dr. Arun Kumar explained, and there is clockwise and counterclockwise rotation, which has to be assessed in the chest lead, sir.
Yeah, that is a see loop is for limb leads and rotation is for the chest leads. No, so loop is more important. And
Yes, sir, so here loop is important.
the loop is more important. The rotation is mostly to patients with right ventricular hypertrophy will have what rotation?
Sir, counterclockwise.
No, the other way around. Clockwise rotation. And the patient with the LV hypertrophy will have counterclockwise. You have to look from below and find out what is the rotation. So when the right ventricular hypertrophy is low, it goes in the clockwise direction, and when the left ventricular hypertrophy is, it goes in the counterclockwise rotation. But that is not very relevant. Well, it does not mean anything other than RVH and LVH. But the clockwise, the clockwise and this L loop and D loop, this the looping is the most important electrocardiography abnormality that will help you to diagnose congenital heart disease. So that you have to draw and show you, and then only it will be understood. It is very difficult to explain and show. You need a drawing. If you want a discussion on how to find out the loop, we'll have a discussion on ECG looping. That's not a problem.
Okay, sir.
Okay, right. Yes. So this ECG, I would favor tetralogy of fellow still because of the. But I agree with you that axis is 150. That's slightly odd, but still it is possible. It could be tetralogy of fellow. Okay. Now we will go to the X-ray chest.
Sir, I have X-ray, but I don't have, sir, echocardiography.
Does not matter.
Okay.
Okay. Any comments? Okay, Ronak, do you give your comments?
Sir, this is chest X-ray PA view showing uh, there is no there is no cardiomegaly.
Okay.
The left out for the apex is of RV type.
So you should describe the left border. You should there is a cardiomegaly, no cardiomegaly.
No
Then you
cardiomegaly.
the left border, the above from downwards, aorta, the pulmonary artery segment, and then
I'm not sure about the side of the aortic arch as I'm not able to make out aortic knuckle. There is a
you make out you make out the side of the arch by looking at the aortic knuckle.
no sir, sorry sir, not by the indent. No sir.
How do you make out whether the aortic arch is right side or left sided?
Indentation over the
Indentation, sir.
Indentation where?
Indentation of trachea, bronchus.
Trachea. See, the concavity of the tracheal indentation tells you about the side of the aortic arch. And also, you can also look at the descending thoracic aorta, but that is not 100% because sometimes when a patient with right side aortic arch, sometimes it may suddenly cross to the left side and the descending thoracic aorta can be on the left side. But ideally, you should clearly look for the tracheal indentation. Then only you can discern. Here, there is some difficulty in making out the tracheal indentation. I also cannot make out where is the real tracheal indentation. If there's a tracheal indentation, we can be reasonably certain. But here, I am not seeing any indentation on the right side.
Right, sir.
So I am not certain whether there is an indentation on the left side. So since I am not seeing any indentation on the right side, I will go for a left side aortic arch. What is the incidence of aortic arch in pathology of fellow? Left side, right side aortic arch?
25%.
25% have right aortic arch.
Okay. What are the conditions in which there can be right side aortic arch?
Tricuspid atresia and truncus.
No, not common. Tricuspid is
Truncus.
Truncus, yes. Truncus is about 50% of cases, 40 to 50% of cases of truncus can have right side aortic arch. Okay. Second, what atresia?
Pulmonary atresia, sir.
Pulmonary atresia, about 1/3. About 30% of 30 to 35% of patients with pulmonary atresia can have right side aortic arch. Next is pathology of fellow. 25 to 30% of patients with tetralogy, but about 1/4 of patients with tetralogy of fellow can have right side aortic arch. Right side aortic arch is usually associated with more severe form of tetralogy of fellow. Okay. Then ventroseptal defect, what is the percentage with right side aortic arch?
4 to 5%, sir.
Okay, around 5%. 5% of patients can have right side aortic arch. In transposition of great arteries and tricuspid atresia, right side aortic arch is very uncommon, especially in transposition, it's very uncommon. Very rare. Okay, right. Yes. So here what about the pulmonary artery segment in this patient?
Main pulmonary artery segment is not seen, not visible.
Yeah.
Left pulmonary artery is also is not is also
are very small. See, right side and left side both. Right pulmonary artery is very small, and left side the pulmonary vasculature is small. If the apex, does it suggest the RV or LV type?
RV type of apex.
RV type. Is the X-ray consistent with the tetralogy of fellow?
Yes, sir. Yes.
Yeah, X-ray is consistent with tetralogy of fellow. Yes. Okay. And echocardiogram, what did it show?
Sir, I don't have the images, but there is just a report.
Okay.
It has mentioned like RARV are slightly dilated, pulmonary artery is narrowed, valve are normal, RV wall is slightly thicker than the LV wall, and a large 14.1 millimeter echo dropout is present in interventricular septal with overriding of aorta. Interatrial septum is intact, and no intracardiac thrombus or mass, suggestive of a tetralogy of fellow.
Okay. So in tetralogy of fellow echo, what are the important points that we look at? One important point has not been mentioned here.
The size of the pulmonary artery.
Yes, the size of the pulmonary artery, that's extremely important. And also you should find out whether there is a
Aortic agitation.
the confluence and what is the size of the main pulmonary artery, what is the size of the right pulmonary artery, left pulmonary artery, and is there a good confluence? All those things should be looked into. That should be commended. Second point.
VSD location and size means
Usually it's
Overriding,
an
how
RA.
much overriding, sir?
Beg your pardon?
over.
Overriding of aorta, how much overriding of aorta is present?
Usually that is less than 50%. If the overriding is more than 50%, you should suspect
DORV.
URV. So usually if less than 50%. But one important thing you should look at is coronary arteries.
Yes.
What is it that you are specifically looking at?
Sometimes left can arise from right.
Artery arising from the
LAD arise from right coronary.
That's the most important thing. LAD can arise from the right sinus or from the right, sometimes from the RCA, but mostly from the right sinus. Then what happens? What is the problem?
And it courses, sir. Is it
course
coursing over the RVOT or between the...
It courses between the pulmonary artery and right ventricle. During procedure or when there is increase in pulmonary artery pressure,
what did you say? It travels between pulmonary artery and the right ventricle. What do you mean by that?
No, between RVOT and during the pressure increase in the RVOT pressure, it can get compressed. And guess.
Very unlikely. That is not the reason. Where does the lady lie? In which groove?
Interventricular.
Interventricular groove. When it arises from the right sinus or the right sinus, how can it reach the interventricular groove?
So it will go between the pulmonary artery and the aorta.
No, it does not go. When does that happen? That happens in a patient where the left coronary artery is arising from the
pulmonary
right sinus. When the LAD is arising from the right sinus, the LAD crosses over the RV outflow to reach the interventricular septum. Reach the interventricular groove. So if the LAD is crossing over the RV outflow, then during surgery, the surgeon should be given warning that there is a LAD crossing and he should not damage the artery. So that's the most important point. Every time when you do an echo for the tetralogy fellow, you should always look at whether the LAD is arising on the right side and whether LAD is crossing over the RV outflow to reach the interventricular groove. And if it is crossing the RV outflow, then it is extremely important to tell the surgeon about that finding, and the surgeon has to take all precautions to see that it does not damage the left antidescending. If the surgeon accidentally damages the left antidescending without getting the correct information, then that may be detrimental to the patient. So it's extremely important to look for the coronary anatomy, coronary anomalies, out of which one of the most important coronary anomaly is the LAD arising from the right sinus and crossing over the RV outflow to reach the interventricular groove. And in this patient, surgeon should be very careful when he operates on when he does a total correction or in a intracardiac correction of a patient with tetralogy of fellow. Okay, right, yes. So that also should be looked into. Ronak, you should always look at the coronary anatomy. Then that's extremely important, and you should not and also always there should be a comment about the size of the main pulmonary artery, whether there's a good confluence, the right pulmonary artery, left pulmonary artery, all those things should be mentioned, especially when you are planning a total correction. It is very important to look at the size of the pulmonary artery. Okay, right, yes. What is the adequate size of the pulmonary artery, Saroj?
We have to measure the diameter of the LP and RPA to be divided by the diameter of the descending aorta at the level of the diaphragm. That it should be more than 0.75. Sir, I am not sure.
Yeah.
More than 1.1, more than 1.2 is operable, and less than 0.8 is strictly it is abandoned for the surgery, sir.
Yeah. It should be more than 0.8, so that it is better to remember that way. Usually it will be around 1. So it is actually the size of the branches are compared to the descending, the size of the descending thoracic aorta at the level of the diaphragm. And the ratio should be around 1, but definitely should be more than 0.8. Okay, so that's very good. So what is the management, Ronak? Now, so we have got all information. And would you like to do a coronary, would you like to do an angiogram in this patient, hemodynamic study?
Yes, sir. Yes, sir.
Why do you want to do a hemodynamic study?
To see for the coronary anatomy.
Oh, no, I think nowadays echocardiogram is enough. A good echocardiographer can definitely detect the coronary anatomy unless you have got a doubt. If you
then a VSD, any missed VSD or any
So to see for any additional VSDs
additional
and
VSD.
the LV angiogram is required, especially when you are suspecting additional what VSD? Muscular VSD. Additional muscular VSD. So you would like to rule out the presence of additional muscular VSDs, then you have to subject the patient for a LV angiogram. In what way you do an LV angiogram to look at the muscular VSD, Ronak? What is the view?
Sir, LAO 70, cranial 40.
Oh, 70 LA is very difficult. Okay. Okay. It should be an LAO with cranial tilt. If there is a LAO with cranial tilt, we will be able to see the interventional spectrum very well without any foreshortening, and you will be able to pick up the muscular VSDs. Okay. So the LV angiogram is required, especially when a patient where you would like to rule out muscular VSDs. And also LV
and sir, additional, if there is a collateral is there or not, to see for the collaterals.
Yes. How do you make out collaterals? What angiogram will you do?
Aortograms.
Where?
Ascending.
Descending,
at the root of the aortic root, sir.
Aortic root.
Non-selective view, sir.
Before you do non-selective, you have to make out whether there are collaterals, whether there are major aorta pulmonary collaterals. Arun Kumar.
Descending thoracic aorta.
Descending thoracic aorta. You should do an angiogram of the descending thoracic aorta, detect the collaterals, and then depending upon, and also you should do a selective canalization and do a
coil, if there is a coil, then coiling.
Collaterals to make out whether they are end arteries. What do you mean by end arteries?
They are not communicating with any.
They are directly supplying lungs, any part of the lung.
Supplying the lung. See, if some of these collaterals may be directly supplying the lung, or maybe communicating with the terminal branches of the pulmonary artery with no communication to the main pulmonary artery. And if you ligate these collaterals, what will happen?
Pulmonary infarction.
Pulmonary infarction.
That much part will, yes.
Yes. So you should always make out whether the collaterals are joining the pulmonary system or they are end arteries. So then only your evaluation is complete. Okay. So, and once you think that is suitable anatomy, you can do a corrective procedure which involves the closing of the VSD and widening of the RV outflow so there is no obstruction. Previously, when there is a repair of the RV outflow was done, there was a problem that many of these patients develop pulmonary regurgitation. And nowadays, surgeons are especially careful not to create a significant pulmonary regurgitation. Originally, it was thought that pulmonary regurgitation may be harmless and the patients can have a long life. But now we know that pulmonary regurgitation can progressively cause RV dysfunction and the patients can develop RV failure. And nowadays, surgeons are very careful to see that the RV pulmonary regurgitation is minimized or there is no pulmonary regurgitation. And what will be a successful surgery? What should be the relationship of the RV to RV pressure to LV pressure for you to say that the repair has been successful? What will be the what should be the RV pressure in relation to LV pressure? Any one of you? What should be the RV pressure, systolic pressure, for you to say that the surgical correction has been successful? Any one of you? Arun Kumar?
I don't know, sir.
Ronak?
No idea, sir.
Saroj?
I don't know, sir.
It should be less than 2/3 the LV systolic pressure. RV pressure should be, RV systolic pressure should be less than 2/3 the LV systolic pressure. Then you can say that there has been a successful correction, total correction. What are the main complications of total correction?
PR, pulmonary regurgitation.
And which can progressively go into RV failure. Okay, right. 1, 2.
And there can be restenosis also, sir, in the due course.
Less common. Okay, but mostly they go for RV dysfunction. That's a big problem. When the VSD is being bundle branch, they can develop right bundle branch block, and these patients have got higher risk of developing
arrhythmia, sir.
Arrhythmias, sudden cardiac death because of the ventricular arrhythmias, ventricular tachycardia. So in a patient with nephrology fellow, if there is a right bundle branch block with left axe deviation, you should be very careful because these patients have got a higher risk of developing major arrhythmia, sudden cardiac death, or they may even go for complete heart block and sudden death is possible. So major arrhythmias, that's another problem. So major arrhythmias, then development of RV dysfunction, and sometimes these patients can, as somebody has pointed out, can develop restenosis also, and can be sometimes, then those patients can be tackled by stenting and all. Okay, so those are the usual things. And what is the mortality of total correction? Mortality.
1 to 3%, sir.
How much?
1 to 3%, sir.
Less than 5%. You are right. It's less, in good centers, it is less than 5%. It's a very useful surgery, and once it is well done, the patients can lead a near normal life. Okay. Any
Sir, I'm not actually. I have doubt that means I'm not able to understand the surgical procedure that is done in that is total cardiac repair. What is mean by total cardiac repair? I'm not getting it, sir, properly.
What are the abnormalities in nephrology fellow?
Sir, ventricular septal defect, RV hypertrophy, and pulmonary stenosis.
Okay, so there is a ventricular, so they have to close the VSD and widen the RV outflow.
Okay.
So once sometimes they may have to use a patch to widen the RV outflow. So two main abnormalities are tackled. One is they close the VSD and they widen the RV outflow, so that there is no more pulmonary stenosis. So pulmonary stenosis, the most RV outflow obstruction is the most important point, and that has to be corrected by doing. Sometimes you may have to give a patch, and sometimes they may be able to, if the muscle tissue is there, sometimes surgery can widen the RV outflow even without doing a very significant, without putting in a very significant patch. Patch should be placed carefully, because if there is a big patch at the RV, at the valvular level or the annulus level, sometimes there is a risk of developing pulmonary regurgitation. That's when the pulmonary regurgitation can progressively going for RV dysfunction. So two corrections to be done is one VSD closure and the widening and opening up of the RV out.
And sir, there is a palliative shunts are made during the early childhood. There is between the 3 month to 6 month or up to 1 year. So that is for the to increase the pulmonary blood flow. No? Means.
Yeah, it is to increase. Nowadays, no, it is not recommended unless what is the indication for shunt surgery, bariatric shunt surgery, or improving the pulmonary blood flow in a tetralogy fellow at the moment.
Severe cyanotic spell emergency.
Yeah, there's a patient having a recurrent cyanotic spell. Yes.
Okay.
The baby is very small and less weight, and there is a severe pulmonary artery size is very less.
Yeah, if the pulmonary arteries are small, if the pulmonary artery, main pulmonary artery is small, pulmonary artery branches are small, then a shunt is given for for developing the pulmonary artery into a larger size vessel, so that at a later time the total correction can be done. So if a BT shunt has been done, you have to close the BT shunt after the total correction is done.
Okay. So,
And
sir,
nowadays BT shunt is not down; it is actually Gore-Tex shunt. Because BT shunt has got the problem that it is actually end-to-side anastomosis, where you sacrifice one of the subclavian arteries.
Artery to opposite side of the aortic arch.
Yes. So it is actually a end-to-side anastomosis, and the pulmonary artery, the subclavian artery has to be sacrificed. Now that is not being done. It is actually Gore-Tex shunt. Gore-Tex is a prosthetic material.
Modified BT shunt.
Modified BT shunt by using a Gore-Tex material, where it is a side-to-side anastomosis, and there is no sacrificing of the subclavian artery. So once the shunt is closed, the subclavian artery can flow normally.
So sir, means on the emergency basis in early childhood, BT for the palliative surgery is done for the survival of the child, and if the baby
life-threatening symptoms like recurrent episodes of cyanotic spells, or if the pulmonary arteries are small, and for the development of the pulmonary artery, you can give a BT shunt. But otherwise, now in most centers, surgeon would like to operate on these patients at a younger age itself. When the baby is around 5 to 10 kilograms, I think surgeons can operate. And the earlier the surgery, the better and good will be the development of the baby.
So sir, there is no criteria for total correction, means age criteria. Before the certain age, can't do total correction, or like
Depends. For example, if the patient is having a good pulmonary vasculature, the pulmonary artery size is normal, everything is fine, earlier the better.
Okay.
If the pulmonary arteries are small and you feel that the pulmonary artery has to be developed, then you should wait till the time the pulmonary artery has sufficient size so that the surgeon can do a good job. Where there was a question, when do the patient, sir, the patient needed redo surgery. Nowadays redo surgery is not very often done, because if the patient is developing restenosis, sometimes the stenting is done without the pulmonary valve, and sometimes that would be enough to tackle the situation. So redo surgery is not a very common thing, and for the pulmonary stenosis, if the patient develops stenting of the pulmonary valve can be done, and that will be enough to re-establish the normal pulmonary normal RV outflow. Okay, any other doubts? Somebody is having any other doubts? If there are no more doubts, we'll. Okay, I think we have discussed most of the points in tetralogy of fellow. If you get a tetralogy of fellow, these are the usual questions that can be asked, and you should be able to answer without any difficulty.
Yes, sir. Yes, sir.
Okay. And next class, what would you like to have? Arun Kumar, would you like to bring a case?
Sir, I'm a little bit busy with thesis, sir.
Eh?
Busy with thesis work, sir.
Anybody who can volunteer to bring a case so that you can discuss the case. So once you are discussing the case, you will develop more and more greater confidence. You will know what are your deficiencies, and that will help you to pass the examination without any difficulty. You should discuss, go on discussing. Then only you will know your deficiencies. Saroj, would you be able to bring a case next week?
Yes, sir, I will bring, sir.
Okay, so we'll have a case from Saroj next week, and after that we'll have one more session on spot test, or I can bring a case and that will be discussed. So next week it will be a case from Saroj. So let us discuss that case also, so that by discussing cases and various types of cases, your confidence as well as clinical discussion abilities will definitely go up, and then you'll become more confident. I think most of you are becoming more and more confident, and understanding of the hemodynamics also is extremely important to explain the symptoms. Okay, let us stop at this level. Thank you. Thank you all. Okay.
Thank you very much, sir. Good night,
Thank you,
sir.
sir. Thank you. Thank you.
Bye.
Thank you, sir.
Thank you, sir. So from here now I'm ending the meeting. Thank you.